What I would like to talk about today is plaque, proof, and prevention, and to rethink cardiovascular risk. It is important to disclose that I offer CIMT exams. We'll talk about what that is in partnership with CardioRisk. That is a financial conflict, but what I want you to take away from this talk at the end is not that you need a CIMT. That is not the message. The message is you need to know if you have plaque, and there are many good ways to do that. Many good ways to do that. Like Dr. Sotomoto, I think it's important to highlight my bias. So I identify as a recovering vascular surgeon. I still practice. I scoop this plaque out of people's arteries every day. And this gives me a bias against this disease because it is awful. And I am here because I need to put myself out of business as a surgeon. I need to put myself out of business as a surgeon because the disease I treat is awful. And the operations that I offer are slightly less awful, but still don't cure the disease of atherosclerosis. It is like putting a Band-Aid on a hole in the Hoover Dam. It does not fix the problem. I also personally use and prescribe a therapeutic carbohydrate reduction approach for more than 90% of my patients. That number is a little lower than Adrian's, probably because in California I struggle with a number of patients who really adhere to their whole food plant-based approach, and that's fine if it works for them. I have a number of certifications in this metabolic space, and one more shout out to the Nutrition Network and their upcoming course on cardiovascular disease, in which I am a faculty member. So, we just had a break. I'm not going to make you stand up and have an exercise snack, but I want you to raise your hand in this room if you have been given a mammogram. Okay, good. Keep your hands up. How about if you have ever had a colonoscopy? Awesome. That's most of you in this room. Lastly, anybody who used to be a smoker in a past life, how many of you have been screened for lung cancer? Couple. Good. So how many of you went to your doctor, your regular general practitioner, primary care, and had them say, oh, look, you're 45 years old. It's time for your cardiovascular screening? That's a cricket I hear back there. That's a cricket. We have an entire set of guidelines about screening your breast, screening your cervix, your colon, your lungs, or your prostate for malignancy. And why is this? Because cancer, when detected early, is much more treatable, and the outcomes are significantly improved. That makes really good sense. We should do that, and we do. Great. But what about cardiovascular disease? Cardiovascular disease causes 1 in 3 deaths annually, which is more than all cancers combined. Cardiovascular disease kills more people than all cancers combined, and we do not screen for it. I said we were going to bring this back to the individual person level, so let me make this very personal. This is a case study, a patient of mine. It's an N equals 1, right? Dr. Hampton has talked about that in the past, and it has a lot of power, so let's do it. Many of you will recognize a panel like this, right? This is a lipid panel, elevated total cholesterol, elevated LDL, yeah. But beautiful HDL and triglycerides, right? The vaunted ratio of less than 1. Huge number of LDL particles, but they're they're large. And her number of small particles is low, so that's reassuring. We have some inflammatory markers here. So hsCRP, which is a body-wide measure of inflammation, high sensitivity C-reactive protein, is optimal at less than 1. LP-PLA2 is a vascular-specific marker of inflammation, and that is elevated, has been on repeat lab testing. Her ApoB is predictably high, but her insulin is low, and that's great. This patient has followed a low carbohydrate way of eating for many years. She is incredibly active, exercises every day, combination of resistance and cardiovascular training. And she's always had normal blood pressure. She's never been a nicotine user. Otherwise, she's in excellent health. Homocysteine's a bit elevated. We can talk about that another day. So this patient comes to me and says, so am I okay? Right? I have looked at the data about isolated ApoB. I've looked at the data on primary prevention for lipid-lowering therapy in women, which is not great. Am I okay? How do you know? Well, what most people do is use a risk calculator. And you won't believe this, but Dr. Sotomoto and I have not coordinated our slides. In fact, we've never formally met, but you're going to see a lot of the same points here. And I think it's because this is really important. We are trying to move away from probabilities and into reality that we can see. So if you put this patient's numbers into the American Heart Association risk calculator, you get a risk of 7.4%. This is largely, by the way, driven by her age. That is about, and her total cholesterol. But her systolic blood pressure is perfect. Her diastolic is perfect. She's never been a smoker. She's not diabetic. She doesn't have high blood pressure. So largely this number is driven by her age, and that is a theme throughout cardiovascular risk. The older you are, the worse your risk is. But this gets really personal, okay? Because this patient is not just a patient. This patient is my mother. You met her yesterday, right? I don't care about her 10-year risk. She is going to be here for much longer than 10 years. I need her to be here for decades, not just years. And if you asked her what her most prized possession would be, it would be her brain, right? I don't need her to be here for decades but unable to function. She has years more work to do. She is on a mission, if you didn't figure that out yesterday. So, 10-year risk calculator is not that compelling to me, right? I actually want to know what her risk is of needing something from me as a vascular surgeon or one of my cardiology friends in her 90s, because those are pretty terrible conversations to have. And I really don't want her to suffer with dementia or a stroke or to need procedures. So as somebody who lives in fear of advanced cardiovascular disease, because that is my bias, and because I love this woman very much, I am not satisfied with just knowing the data at the population level and her predicted risk based on epidemiology. So let's talk a little bit about prevention, because in my opinion, we're doing it wrong. This is a tree talking to another tree, asking if he's heard something, because a tree fell in the woods but nobody heard it. 20% of heart attacks are asymptomatic or silent. Patients never have symptoms. But we know later that there has been damage done to the heart. It's about the same proportion of stroke. It's 8 to 10 million annually in the United States. That equates to 20 to about 30% of strokes are silent. These events still cause damage. That's how we find them later. We see it on an EKG, or we see it on an MRI. Areas of the brain or the heart that have died because of an event that was silent. But if you ask people like me or your cardiology friends, we'll tell you that we don't treat this disease surgically until the area that's narrowed is about 70 to 80% narrowed. That seems crazy. It's crazy, right? Why would we wait when we can detect this at 50%, 60%? And what I can offer you is that surgery is a bad tool. Believe me, the medical establishment would happily treat this at a much earlier level if we could have shown that it worked. It doesn't, right? Stents, open operations, these are very crude tools for a disease that I will argue we still don't fully understand. So surgery is not the answer. Stents are not the answer here, because we have studied it and we know treating this disease early that way is not effective. It increases risk and does not improve outcomes. Nevertheless, do you want to be told you're fine until you have severe stenosis or a symptomatic event? How much damage are we allowing to happen to our patients and our families when we have this approach? Part of this is a definition problem, and this goes back to a little bit of the epidemiology, right? In the public health space, there are different kinds of prevention. So primary prevention is classically defined as somebody who has never had a heart attack or stroke. Secondary prevention means, whoops, you had that event, sorry, but let's really try to not have another one. That is secondary prevention. But what happens if you have severe disease inside your vessels and have not had an event yet? Should we wait before we treat? Dr. Sotomoda answered this question a little bit earlier, looking at Matt Budoff's study. I'm going to show you the same paper again. And again, my answer is probably not, because early detection, when treated appropriately, preserves critical tissue, and it allows us to direct treatment where it is most needed. So I need to switch hats for just a minute here. We're going to take a little diversion, because as much as my bio here always says MHP, which is true, I am a certified metabolic health practitioner, and I never correct Doug because it's confusing. I also have a master's in public health, an MPH. So I get both. And we need to talk a little bit about what defines a good screening protocol, because this matters at the public health level. So to be worthwhile, to be valid, a large public screening protocol must fulfill multiple criteria. It should detect a common condition. The screening tool of choice should be effective and safe. It should be accessible and reasonably priced, and it should lead to improved health outcomes. So when we ask, why on earth do we not screen for the most common cause of death in men and women in this country, you have to believe that the answer is somewhere in this list. And it is. For sure, cardiovascular disease is a common condition. I think we can all agree about that. We have shown you already today that there are multiple effective tools to detect the presence of plaque or disease. Generally speaking, they are safe. Accessible and reasonably priced is I would say, come see, come saw, right? In general, CAC is widely accessible, more than it used to be, and fairly inexpensive, but it's still not covered by most people's insurance unless they meet intermediate risk criteria on a calculator. And that is because it's not officially a screening, so it's a little bit of a catch-22. You can't get approved and be accessible until you're anyway. Other techniques like CCTA or CT Angiography and CIMT are less accessible and more expensive, but they are coming down in price and increasing in accessibility as more and more people become citizen scientists and take their health into their own hands and demand these evaluations. But truthfully, the real sticking point here is this last one. A screening test needs to detect disease early because by definition, early detection allows improvement in the outcome, right? That is true of cancer. When we detect early stage disease, the interventions meaningfully alter the trajectory of patients. We in medicine have failed in cardiovascular disease because we have been unable to prove, thus far at a large level, that early detection has led to significantly improved health outcomes. That's on us. We did that. And why is that true? This is Dave Feldman's work. Thank you, Dave, for providing me this slide so we can talk about it. This is the waterfall plot showing the progression and regression of plaque in this cohort in the LMHR keto CTA trial. My interpretation of this is that certainly there was no correlation with ApoB or LDL-C, right? We've discussed that. I think we can all agree about that. So why are some people progressing rapidly and other people regressing? My opinion, my hypothesis, is that there are multiple phenotypes of atherosclerosis, right? Rob Saiwas told us that atherosclerosis is a secondary disease. It comes as the result of nicotine or insulin resistance and diabetes or genetic predispositions like FH or Lp(a), right? There are multiple different reasons, and they can be combined, why people develop plaque and why plaque may progress. But our inability to understand these phenotypes and the individual risk factors that contribute and address those means that we have done a pretty terrible job figuring out how to intervene appropriately to improve outcomes when we detect disease early. For decades, we have just said, take your aspirin, take your statin, we'll see you in a year. And we are shocked when that isn't effective. So let's just carry on and say, all right, maybe we don't meet criteria for screening. All right, I can accept that. Let's talk instead about early detection. Because screening says everyone gets tested, right? Every woman over 40 is recommended to have a mammogram. Everyone over 45 is recommended to be screened for colorectal cancer. Screening says everyone gets tested. Early detection says that those with known increased risk should be tested. Well, how many people is that in the United States? Right? You know this slide. I'm not going to go through it. About 12% of the US population have zero criteria for metabolic syndrome. So we don't need to screen everybody. I'm fine with that. Let's just screen the 90% of America that has increased risk for cardiovascular disease based on one or more risk factors for metabolic syndrome. I don't think that's a huge stretch. I also think we need to redefine prevention. Primary prevention should be no plaque. Secondary prevention should be patients who have plaque but have not yet had a heart attack or stroke. And tertiary or third order prevention should be those patients with a history of heart attack, stroke, or peripheral arterial disease, PAD. And when you think about people like me who work in a hospital setting who treat patients with atherosclerotic disease, and you recognize that we almost exclusively treat patients who've already had heart attack, stroke, or PAD, we're failing. We are failing these patients. So again, here's the current standard. This is the pooled cohort equation. This has changed a little bit since I made this slide, but overall, general risk factors, right? Many of which are related to metabolic syndrome, some of which are not. But if you don't like that, we have others. We have plenty of other calculators that can be used. Framingham was kind of the OG. We also have the Reynolds score, specific to women, and the MESA score that Dr. Sotomoto referenced earlier. None of these answer the question that you should be asking. The real question you want to know is, do you have disease or not? That is what predicts your progression, right? Plaque begets plaque. If you have disease, you need to be more aggressive in figuring out what your risk factors are for progression and mitigating those. If you do not, great, go live your life. I'll see you in a year. So my proposal is that the new standard for clinics, for those of us who are treating patients, needs to be knowledge. We need to quit guessing. Let us quit thinking about population risk applied to an individual patient. Let us know and not guess. We have multiple options for direct assessment that are safe, reproducible, and cost-effective. Now I'm going to give you a menu of options here, and it's going to sound like I have some bias about which one you pick. Yes and no. These are not mutually exclusive, and what I tell you about them should not be interpreted to say you get one, not another. They are all good. They can be used in combination or in isolation. They have different functions and different purposes. Just like Adrian said, kind of depends. How old are you? What kind of predisposing factors do you have, and what are we trying to do, and what are we trying to answer? But those options include CAC, coronary CT angiogram with or without an AI overlay, like Clearly or HeartFlow, carotid intimal medial thickness with a plaque assessment, or CIMT. So we've talked a lot about CAC. I won't belabor the point, but if you've never seen pictures, let me show you what CACs look like. So this is the heart. You can see the spine back here. This is a CAC of 0. It is all this nice gray color. There's nothing white or shiny here. CAC of 29, right? A low risk CAC less than 100. There's a little speck right here that you can see. That's the bit of calcium. And by the way, this is an Agatston score, right? So this is a nice, very reproducible evaluation that whether you get it in Miami or in Minnesota, the score means the same thing to all of us around the country or around the world. A CAC of 250, you start to see the outline of the coronary vessels, and CAC of 1200, now things are so bright that the vessel is basically outlined in calcium. CAC is exceptionally well validated for 10-year risk, and the cardiologists absolutely love it. And when it is positive, it answers the question of, do you have disease? It is reasonably good at saying, if you have disease, but we don't detect it, it won't cause a problem for 10 years. That is the power of zero. If you have disease, but we don't detect it, its chances of causing you trouble in the next 10 years is exceptionally low. But it doesn't mean you don't have disease. So it does not image this soft plaque. And the interval at which you should repeat it, because none of these are one and done, none of these should be one and done, is a little unclear. Is it 2 years? Is it 5 years? We don't really know. But most people would say when you're going to repeat your CAC, somewhere in the 2 to 5 year range would probably be reasonable. The radiation is low, but it's not zero. It's some exposure, right? And especially if we're talking about repeating things annually or semi-annually every few years to understand progression of disease, we should just acknowledge that the radiation is low but not zero. So this is widely accepted. The technique is very consistent. You can now walk down the corner almost and get this at any imaging center. So it is much more accessible, and it's, of these options, by far the least expensive, right? Maybe $100, $150 in many, many markets. It does not image soft plaque. And if you are younger, this is more important. If you are older, and we'll talk about this, it's okay, right? It actually is much more meaningful, but again, 10-year risk, not lifetime risk. It is less sensitive and timely for monitoring therapy. For many of you in this room, that is less of a concern. For me, as somebody who really digs deep into these patients who are very high risk, I like to be able to monitor and run these experiments to see, is the thing that we are doing working? Is the plaque getting better or at least staying stable? Dr. Sotomoto made reference to this. CAC does not mean the same thing. So a CAC of 0 at an age of 38 is very different than a CAC of 0 at age 78. Those mean wildly different things to me. And when we talk about CAC for all, we lose a little of that nuance. This is also different by gender and by ethnicity. We don't talk much about that, but for women, we know that there is about a 10-year protection window conferred by estrogen, right? And so women tend to develop their heart disease events about 10 years later in life than men. So those reference ranges and those percentiles should be interpreted a little differently. They should also be interpreted differently if you are treating predominantly, or not even predominantly, excuse me, just be aware that those percentiles are different if you are treating patients who are Black or of East Asian heritage. The percentiles are different. If your lab is not reporting them as such, just be aware that these things do matter. We've already seen this figure. But this is Matt Budov's paper looking at the progression of events relative to your CAC score. We're just going to focus on one of these. And my interpretation is just a little different than Adrian's, and that's my bias, right? That's my bias about wanting to prevent the suffering that I see associated with this disease. So I am more aggressive than many people in this room about preventing and treating this at a very early stage. Because what I want you to see is that the event rate for people with a 0 CAC is not 0. There is a real event rate that is associated, and it's about 5% by that 6 to 8 year mark. For people with a low CAC, which most people will say, meh, not over 100, don't worry about it. But there is a monotonic, nearly linear increase in risk as CAC goes up. So if you have a 1 to 99 score, your rates of major adverse cardiac events or late revascularization is nearly doubled at 5 years than it is if you have a CAC of 0. So it's low risk, but it's not no risk, and it is more risk than your CAC of 0. Now again, a CAC of 300 is equivalent in event risk to have already had heart attack or stroke. So this is evidence for what I already argued, which is patients with severe plaque should be secondary prevention patients. We need to think of those patients more like people that have already had an event, because the proof is in the pudding. They behave that way. They behave that way. So this is a real possibility as we move forward into the new era of thinking of cardiovascular risk. So my question to you is, when do you want to know? When do you want to know that you are at increased risk? Because if you get your CAC of 0 and you go on for the next 10 years and think, my CAC was 0, I'm good, it's very likely that you may find that that's not entirely correct. Now, 2 CACs of 0 separated by several years, that is incredibly powerful. That is very compelling for low risk. So that's a good metric. But 1 on its own, a little less compelling, and there may still be real risk there. So even if you are low risk, do you want more information to know whether you can prevent major events or revascularization? I would argue that CCTA is the new gold standard for assessment. Again, we've talked a lot about this. I'm not going to belabor the point. The difference here is that we now have contrast dye that is injected into the vein during the scan. And so the contrast fills the blood vessels, and now we are able to see both the calcified plaque and the soft plaque. So here you can see that there is a very high-grade stenosis here, and it's dark. There's nothing bright white here. There's no calcium. This is a lesion that it would only be detected by CCTA. So CCTA gives us an enormous amount of information. It detects all plaque. It has excellent reliability and repeatability. And the new overlay technology, I have to say I'm a little more suspicious now that we've seen some comparative data, but in general, I would say it is promising in the future for a way to maximize our utility for analysis and comparison, right? I enjoy being able to understand how much of the plaque volume is calcified versus non-calcified. I find that interesting and helpful. The downside is that there is more radiation associated with CCTA. It's not extraordinary, but it's probably enough I wouldn't do it every year unless I had a very compelling reason to do so. The contrast dye for some patients is an issue, but not everybody. Cost, in my opinion, is really the practical limitation today for this test. You can potentially get the angiogram part covered through insurance if you're symptomatic, so chest pain with activity. But oftentimes when we're talking about screening, we're really talking about asymptomatic people. And the AI overlay thus far, I've not had much success getting covered by insurance at all. So most of my patients who want this are looking at $1,500 to $1,800 out of pocket to get this done, which valuable information, right? You can't really put a price on that, but is it something I would do every year to monitor therapy? Maybe not. So it's an excellent test. Both CAC and CCTA are excellent tests. But I want to talk for a second about carotid intimal medial thickness, because I think this is also a valuable addition to the arsenal. It should not be considered a replacement, but I find a lot of value personally in offering this in my practice. So what is it? Because somebody told me today that they had no idea what this was, and they might have come talk to me sooner if they actually had any idea. So many people come to me asking for the Ford Brewer test. If any of you know Dr. Brewer, he's very active on his YouTube channel, and he talks a lot about CIMT. But it is an ultrasound-based study that looks at the common carotid and the bifurcation into the internal and external carotid arteries in the neck that go up to the brain. And unlike a standard carotid duplex, what we're actually looking at is the thin gray line here, which is the innermost layers of the blood vessel. So back to your basic anatomy, the blood vessel has 3 layers: the intima, the media, and the adventitia. We measure this because thickening in those layers represents the first early stages in the pathogenesis of plaque formation or atherosclerosis. This matters because when I have to go in there and scrape all of this out for patients who've had stroke, I actually don't get to take just the plaque. I have to take the intima and the media with it. So if you ever come to me for a carotid endarterectomy, all that layers come out because it's part and parcel of the plaque. All you're left with is the adventitia. So most people, when they get an ultrasound of their neck, are looking for stenosis. So much plaque that it narrows the lumen or the flow channel. This is not that. This is a different test. It measures that thickness, and the average thickness in a healthy person is less than 1 millimeter. When done well, and that's a big caveat, when done well, this test is sensitive to hundredths of a millimeter of change. The big detraction from this test, and the reason that it is not commonly done, that the AHA does not recommend it, is that it is examiner dependent. Ultrasound is much more technical than a CT in terms of who does it and what the study shows. To do this well, you need to bring your exam to a lab that makes a point of making these measurements reliable and repeatable. Let me segue for a second, because I said I do this with CardioRisk. Dr. Todd Eldridge, who runs that company, is an engineer, not a physician, and he has made his entire career about reducing variability. And for the science nerds here, you will appreciate that. For the medical people in here, you will appreciate that I have done a decade of training to be a surgeon, give or take. Not once did anybody ever measure my technical skill against a standard. Not once. They sort of looked and like, meh, good enough. Dr. Todd Eldridge said, you want to come scan for CardioRisk, you have to fly to Utah. You got to come learn with me, and then you have to scan 5 people off the street twice. I'm going to blind your results, and I'm going to pit them against my best sonographer of 20 years, who's going to scan the same 5 people twice. We're going to send that to a statistician outside of the organization, and blinded, we're going to decide, do you guys get the same answer amongst your own measurements and between each other? If you are not within his accepted standard error of hundredths of a millimeter, you don't get to scan for CardioRisk. So this means that this is less accessible. There are not enough people who can do this yet to make it a screening test. But what it does mean is that for those patients who get it, it is reliable. CIMT is normalized to age, just like CAC. The difference, though, is that these curves go all the way down to birth. We have done ultrasounds down to neonates. So we know that, yes, just like CAC, there is a progression over time, but we can norm this no matter your age. So if you are 30 with a terrible family history, we can do an IMT and understand where your risk is relative to your peers. The same cannot be said for that patient with CAC. The other thing that I hear a lot is that, well, this is the carotid arteries, right? That's the brain. This has nothing to do with the heart. Why would we use it? To which I say 2 things. One, atherosclerosis is a systemic disease. It affects the circulation system everywhere. So if you have plaque here, the odds are you have plaque in the coronary system. If you have plaque in your femoral vessels, odds are you have plaque in the carotids and in the heart. That's a nice idea, but is it true? So there are many studies now, including some very large meta-analyses that will show this same point, but the answer is yes, the data support this. The Caves Cave study was done a very long time ago, and it was 13,000 patients with over 100,000 person years of follow-up. And like many of the most interesting studies we talk about at this meeting will never be done today, because part of the inclusion criteria for the trial was that no matter what we found, we would not treat it. So they scanned everybody, And they said, oh, you got terrible disease. Good luck. We'll see you in a couple of years. No treatment. There was a fairly large proportion of smokers in this population as well, and so we can argue about whether this is representative and whether it matters, but overall, the detection rate for cardiac events, major adverse cardiac events, is 98.5%. So it's not a perfect test, but it does represent risk for events in the coronary circulation as well as the cerebral circulation. So this is a very sensitive test. It is well validated. We can detect soft and calcified plaque, and I'm going to show you that in a minute. There is no radiation. So I like to repeat this annually to monitor the effectiveness of my therapy. The other important thing for some people is that this can reduce the barrier to getting stuff done, right? People show up to my office and I can do this for them at the time. There are several people at this meeting who knew they were supposed to have some kind of like checkup or whatever, but hadn't really gotten around to it. The fact that I was here and able to do this meant now we have more information. So this is part of our arsenal. There are several cons to this test. The technique can be variable. The labs can be variable, so your CIMT from cardio risk does not translate very well to your CIMT from vaso labs. Maybe it does or not, we don't know, unclear. It is a little more expensive than a CAC, give or take, and it does not image the coronaries. So for some people that is just a deal breaker, that's fine. But let me show you what this looks like, because I think images are very powerful. Do you have disease or not? So here is your reference image up on the right. This is a normal IMT, very even, quite thin. This is a woman who came to me in her 40s. This is not normal. This is very thickened. You can see the IMT here between the two yellow arrows, and then there's this little boulder here. There's a big black spot underneath it. That is acoustic shadowing from calcium. This is a patient with FH. So arteries are not normal. This patient would have had a positive calcium score, by the way, I imagine, right? There is calcified plaque here in the carotid artery. I imagine her CAC would also be positive. So have we achieved much? I don't know, but we certainly can show this patient in office, in consultation with me, that she has increased risk. What about the soft plaque? What I'll tell you is that this is gray and speckly, right? It's heterogeneous, medium. This is bright white, that's calcified. You can see the shadowing beneath it. But we can also detect very vulnerable soft plaque, right? That's what ruptures. That is what we worry about in terms of acute events, heart attack and stroke. It's hard to see actually here, but there is a tiny, thin, very minute little cap over here and just black beneath it. That is a soft, vulnerable plaque. Let me show you another one, because this is somebody in this room. This is done this weekend. So here's the carotid bifurcation. All you see is this little itty-bitty white line. You might actually just overlook that. But if I put Doppler flow past it, there is a very large soft plaque here. That is not heterogeneous. That is not calcified. That is a very vulnerable plaque heading right up to the brain. This person is now empowered to think about their risk. That is something they have today that they did not have when they walked into this meeting several days ago. Would this person have equally benefited from a CAC or a CCTA? Very possibly. This is not either or. We do not have to pick. We can do multiple or all. It is one more tool in the arsenal that I encourage you to think about and use when appropriate in your patients. So let's come back to my mom, because in 2023, this is, by the way, if you talked to me and I told you that these IMT reports are challenging to read, this is what I mean, and I'm sorry. What I want you to focus on is patient age up here, okay? So in 2023, she was 69, and her arterial age was 64. That's awesome. When your arterial age is less than your chronologic age, you're in good shape. That means your IMT is less than the norm for your gender and age. You do see that she has plaque here, and this is not emphasized enough in this report, but this is a separate deal. When we do IMTs, we talk about two separate things: the actual intimal medial thickness and the plaque, okay? The plaque represents existing disease. Plaque begets plaque. That's important. That is a yes/no question. The IMT, in my opinion, talks about the ongoing inflammation in the wall of that blood vessel. How likely do I think it is that plaque is actively progressing and depositing? So those are two separate questions. So in 2023, Mom and I looked at all this and said, wow, this looks pretty good. Yes, there's plaque, but overall you're in great shape. Let's play. Let's do a little experiment. So we did, and I'll tell you what that is later if you care. But by 2025, we repeated her exam, and now her chronologic age is 71. Her arterial age is 73, which is not so bad relative to her chronologic age, but look at the progression. 64 to 73, that's almost 10 years of arterial age progression in 2 years of chronologic progression. She went from an IMT of 0.72 to 0.81. Average year to year in a normal population and a normal cohort is 0.01 millimeters. She progressed almost 0.1, so fivefold what we would expect in the population. Her plaque burden didn't change much, but in 2 years I wouldn't necessarily expect it to, right? Plaque takes years, if not decades, to form and progress. What this tells me is that she is now at risk for rapid progression in the next 5 to 10 years, right? Which, you know, some people would say, 70-year-old woman, 5 to 10 years, no big deal. But no, that's my mom, okay? It's my mom, it's not okay. So what happened between 2023 and 2025? We ran some experiments, and this is why I am now a little less enthusiastic about nattokinase. But based on these 2025 results, we've pivoted. We now have a new experiment, okay? And when Dave came and talked about how we understand our own physiology, he became famous for his experiments, right? Nick Norwitz is famous for his experiments and the power of that to show us how what we do individually impacts our risk cannot be overstated. This is a big deal because our bodies are not the same. The population data are nice and they are helpful and they are essential, but they rarely inform exactly what will happen with the individual patient in front of us. So how do you make those decisions? How do you decide if the therapy that you're on is effective? How do you decide if your risk is really coming down? This is the power of CIMT. Is this possible with CAC or CCTA? Yes, but with more radiation and a little less granularity for CAC and just more cost for CCTA. This is possible with any of the tests, but this is very sensitive for these changes. And for those people who like to play an experiment, is a very reliable tool to understand the impact of those changes that we are making in our nutrition, in our movement, in our sleep, in our stress, in our medications. I've talked about the power of images, and I think the power of using our eyeballs is critical. So in metabolically ill patients, which is, again, only 90% of the population, NBD, we must treat and detect ASCVD early to maximize health span. When you talk to patients about this, it is possible not only to halt progression, but to reverse plaque. You must give people the hope, and you must have the knowledge and belief, which are not the same, right? Facts and beliefs are not the same. You must know and believe that it is possible to reverse this plaque. So people must have the hope. You have to give them hope that this is possible. And we know in this room that it is possible. Showing people their imaging, whether it's their CAC or their CCTA, if you can have the images and show your patients the pictures, I really encourage you to do that. It doesn't have to be a CIMT. Get the images. Look at them yourself. You'll learn a lot. And show your patients. The pictures make a big difference. Interval imaging also is motivating, right? Patients know, oh, I'm coming back to see doc in a year. We're going to repeat that testing. That's a reminder that I'm going to stick with what I said I was going to do. So if nobody else is offering to screen for cardiovascular disease, if nobody else in your world suggests this, guess what? You're empowered. You can do it. And if nobody else is doing it right, it's our job. I don't care what test you get. I'll say it again in the back. I don't care what test you get. Pick one and make sure it gets repeated. But use some of these, one of these, to find out whether you or your people you love have plaque. The next thing is a little bit of a sticking point. Have a plan for what you're gonna do when you find disease. For some of you, that means you're gonna call me. For others, you will have a network of people that you will refer to and you will understand, but be prepared as a screening test to find disease. Look at your coronary RADS testing. There are recommendations in there for what to do, but have a plan. Use the power of visual feedback to encourage positive change in your patients. Please give people hope that they can halt disease progression. And repeat this imaging at regular intervals. It is not a one and done. It doesn't have to be forever, but at least 2 tests, okay? At least 2 tests. Just like Lp(a), I agree, should be measured twice. Get 2 imaging tests. Just to sum it up, cardiovascular disease is the leading cause of death in men and women, more than all cancers combined, but we do not screen for it. You know better now, so you're gonna do better now. Because you cannot fix what you don't know about. So get scanned yourself, get your patients and the people you love scanned. Thank you.
Have you seen or can you comment on improvement of leg ulcers, context being vascular disease, with TCR or ketogenic diet?
My N is not big enough to comment, so I believe that it is useful and helpful, but ulcers are complex. There are venous ulcers, there are neuropathic ulcers, there are arterial ulcers. It is my opinion that all of them ought to be helped, not harmed, by a TCR approach in combination with other therapy, but I don't have data.
Okay, I tell my medical students that if we understand as much about atherosclerosis as we think, why is cardiovascular disease still the number one?
Yeah, so this is the argument that says if LDL-C were the only important thing about plaque, we would have cured heart disease 30 years ago. We've been lowering LDL-C for a very long time. Now, my opinion on this molecule is nuanced. I do not believe that it is completely irrelevant in the treatment of existing plaque. Does it independently cause it? Less compelling. Maybe it's relevant in treatment but not cause, up for debate. Happy to have that debate. And if it were just lipids, we would have cured heart disease 30 years ago. I would not be up here preaching about early detection of disease.
Okay, Roshni asking, what is the difference between calcium in the plaque and contrast dye and CCTA? Both look white.
It's very apparent on the actual imaging studies, right? But the contrast dye is iodine. It's not a calcium molecule. It may be difficult to appreciate, but they look very different. When we are looking at calcium score, we do that in a non-contrasted phase. So even when you get a calcium score as part of your CCTA, it is an initial non-contrast run before the contrast is injected. So they are both radiodense, they both appear bright, but they are actually not the same, and we tell the difference specifically by measuring them separately.
Won't CCTA lead to stenting asymptomatic patients?
That's up to your friendly neighborhood cardiologist. It can, yes. So I have had several patients who were sort of biohacking and wanted all the testing and got a CCTA and found an 80% lesion. Now, interestingly, it was read by the cardiologist, or the radiologist, as 80%. On an AI overlay analysis, it was actually less than 70. It was 72%, I believe, but significantly lower. And I had to tell him, I was like, look, the recommendation is you got to go see a cardiologist to talk about it. I'm going to tell you that you were out hiking for 6 miles yesterday up hills with no symptoms. I personally would not recommend putting a stent in that. The data for stenting asymptomatic disease, even when high grade, is not amazing. But I'm not a cardiologist, I just play one on television. So is it possible that it will lead to overtreatment? Yes. Is it possible that it will lead to too many procedures? Yes. This is where we all have to be our own advocates, right? Because there's a lot of mistrust right now in the medical system, and it's earned. We messed up. We've been doing it for a long time. So trust but verify. Get a second opinion. If that is what somebody tells you, please go get a second opinion, because reasonable people differ. Our biases impact what happens when you show up with a stenosis, right? I am aggressive about this disease because I see what happens when people show up with it in their 80s, and I hate it. But does that make me overly aggressive? It might. It absolutely might, and I have to acknowledge that. So yes, all kinds of imaging, it may lead to over-detection and over-treatment. Sensitivity, specificity, right? We have to balance the harm of over-treatment versus the harm of having disease and not treating it at all. And there's going to be some play depending on where you fall in that spectrum.
How often should CIMT be repeated after taking HRT and the first scan shows normal carotid?
Up to you. Are you interested in knowing what your HRT did after a year? That's about what we would say is the timeline to see some change, but it could be 2 years, right? If your CIMT was normal and you don't have a concern, you can repeat it whenever you wish. But a year is typically what I offer my patients who are interested. I would say there's really limited value in 6 months or less. For my very young, healthy, low-risk patients with a normal IMT and no plaque, I will extend that out for several years.
In a busy practice setting, what methods do you use to teach people about TCR and encourage compliance?
I take more time. I'm building a metabolic practice that is separate from my surgical practice, even in my insurance-based model, and it's still not enough, but I have just decided that I cannot do it in 15 minutes personally, or even half an hour, right? In my fun outside the hospital practice, my initial visits are 2 hours and my follow-ups are an hour. In my clinic, for my surgical patients, my initial visits are half hour and my follow-ups are 15 minutes, and that is not conducive to metabolic care. So for my metabolic patients in the hospital, I'm now doing an hour for initials and half an hour for follow-ups. It remains to be seen whether I can actually make that work financially in an insurance system, but I'm gonna do my best because I think it's important. I am just not good enough yet to do that counseling in 15 minutes because I do more than nutrition, right? I talk about nutrition and movement and sleep and stress and toxic exposures and their labs and their medications and supplements and their social support, and I cannot do that in 15 minutes personally. Maybe someday, but not yet.
Given that statins increase insulin resistance, would you use a statin on someone with a CAC of 200?
Insufficient data to answer that question. Do I use statins in my practice? Yes, I do. Do I use them for everybody indiscriminately? No, I do not. So, just like Adrian, this is a disappointing answer, but it depends. It's been my experience that the insulin resistance is dose dependent and can be mitigated with lower doses and combination therapy when it's necessary. Is it always necessary? No. And in my patients on therapeutic carbohydrate reduction, I really worry a lot less about any insulin resistance that may crop up because they're not triggering an excess insulin response with their nutritional strategy. So it's a case by case, right? And I have to acknowledge that in patients who have just had a heart attack, a stroke, or a limb-threatening event, our clinical guidelines strongly encourage high-intensity statin therapy as a proven method to reduce major adverse cardiac events and major adverse limb events. And at the population level, it is a measurable real impact. Yes, the number needed to treat is higher than we would like, but at the population level, secondary prevention, it is a demonstrated effect. So for those of us who work in the hospital system with patients who have just about lost their leg or just had a massive heart attack, high-intensity statin therapy is the guideline, and we will do that. If it's my patient, I will do it for a short period of time and see if I can come down on that. Depends on what they're willing to do, right? Many of my hospital-based patients are metabolic disasters and are not in a state where they are willing to contemplate change. When they are pre-contemplative and say, "Doc, you just give me the pill, you just fix this. I don't care, I'm gonna eat what I'm gonna eat, I'm gonna drink my 4 beers a night, and this is really a you problem, not a me problem," my options are a little bit limited, right? So I treat people on a spectrum of readiness to change, and what tools are in my toolbox really depends on the patient. So statins are a loaded question. I use them. Do I love them? No. But do I use them? Yes.
Okay. Is it of any value to do a CIMT for cerebral screening in someone with a CAC score of 0 and a CCTA that shows 0 plaque, but normal vessel volume?
Probably not. I don't think you're going to get a lot of added value if you have both a negative CAC and a CCTA. But if you want information and you want to play year to year about the IMT change and some kind of intervention that you're doing, whether that's more training, different nutritional approach, CIMT does provide an interesting opportunity to run that experiment without more radiation. But do I think you're going to detect something in the cerebral circulation that a CCTA and a CAC missed? It's unlikely, but not never, right? Vascular disease is systemic, but certain people get it in certain vascular beds earlier than others, right? I don't know yet why some people present with stroke, some people present with lower extremity issues, and some people present with MI. It's the same disease. It really is. And if you have it in one place, you have it somewhere else. But why is it that in some people it is dramatically worse in one vascular bed versus another? We don't know, right? Waterfall plot, multiple phenotypes, we don't know. Unsatisfying, sorry.
Are you seeing good results with Zetia as an intervention to slow or stop plaque progression?
Zetia or ezetimibe is a lipid-lowering medication that works by preventing reabsorption of cholesterol in the GI tract. So we excrete cholesterol in bile salts, and we reabsorb it, right? Because the body knows cholesterol is an important molecule, and it's valuable, and it's costly to make. So rather than just excreting it all, why don't we reabsorb it and reuse, right? Reduce, reuse, recycle. So Zetia prevents the reabsorption in the intestinal tract. I use Zetia in combination therapy a lot. I have tried it as monotherapy in a few patients, but it has never really been studied that way. So very few people will ever use Zetia as a monotherapy because the trial data don't exist to support that. Some people seem to be, now we have to talk about hyperabsorbers and hypersecretors, and so you can either make too much in your liver, or you can reabsorb too much sterol from the GI tract, or you can do both. Some people are especially sensitive to ezetimibe, and so the average lipid lowering with Zetia is around 15% of ApoB or LDL-C, but some people actually are disproportionately much more responsive than that. You can get up to 30% lowering with Zetia in some people. There's something called the cholesterol balance test that may speak to this. We don't have to get into that. I use it, but I use it as combination therapy. I won't speak to it by itself.
Okay, it's disappeared. Jenny Updike. So she must be on the live stream, one of our favorite attendees. And if everyone was like her, we would still be having Q&A at the mic. Can you please talk about the CIMT changes you're seeing with patients with GLP-1/GIP medication?
I don't have a big enough patient population to speak to my own cohort. What I will say is that I am very intrigued by the population data for cardiovascular risk reduction using GLP and GIP receptor agonists. So the SURMOUNT trial definitely showed an improvement in cardiovascular risk reduction, or a reduction in risk with semaglutide. I expect we will see that replicated with tirzepatide as well. Whether this is separate from the excess fat loss is still a little unclear. However, I do believe that there is some impact on inflammation, which may actually just be the reduction in visceral adiposity, because that is pro-inflammatory. We don't know, but I find it very interesting, and certainly for patients who are not where they want to be with body composition with a TCR approach, or who are for whatever reason unable, unwilling to achieve complete TCR, I use that as an adjunct. I do find that in people who eat relatively well, just like Dr. Cywis was saying, I need much lower doses to achieve desirable body composition and desirable changes in inflammation and lipid numbers. So I think that we have to be a little thoughtful about how we use it, and I'm very careful to make sure that I don't have excess muscle loss, we don't increase frailty, we don't increase fracture risk. So there's a lot of nuance here. I think they're very exciting agents, but I haven't been able to show any CIMT changes yet. I have not been using them long enough to have a cohort to tell you that for sure it improves. But I think it probably will someday.
Okay, I'm going to combine these two. Dr. Cami and Nelson Vasquez. Cami's asking, does baby aspirin daily prevent soft plaque or help prevent it? And then Nelson's asking, besides aspirin and statins, what else stops progression or encourage reversal?
Okay. Aspirin makes your platelets less sticky. That is the mechanism of action by which we believe that it impacts cardiovascular risk. And it is no longer recommended for primary prevention, meaning everybody is not recommended to take a baby aspirin. That is because there is an increase in bleeding risk for patients who otherwise are very low risk for cardiac disease. So in those patients, the risk of bleeding, the harm, outweighed the benefit. There actually is a significant reduction in everybody for cardiac events on baby aspirin, but if you were super low risk to begin with, your bleeding risk, GI bleed, head bleed, was harmful in all comers. But if you have plaque, I think baby aspirin's a pretty good idea. But it makes your platelets less sticky. To the extent, I don't think we really know whether it prevents progression of soft plaque, but the predicted answer based on what we think we know about aspirin would be maybe not. Can't say for sure, but probably not. Other things, right? So I showed my patient, my mom's homocysteine, which is remarkably elevated. That is one target that I have. Uric acid, as Dr. Cywis mentioned, is another target. Inflammation of any kind, HSCRP or LPPLA2, that is something I will go after, but typically not with drugs, right? With TCR or with getting to the root cause, which is sometimes visceral adiposity, sometimes it's sleep apnea, sometimes it's periodontal disease or an untreated root canal abscess. So inflammation comes from a lot of places, and figuring out where it came from and treating that is a really good idea. Suppressing the immune system by itself without understanding where the inflammation's coming from seems to reduce cardiac events and increase risk of infection with a net neutral effect on all-cause mortality, so I don't typically recommend that. But this is my point about phenotypes in atherosclerosis. Not everybody progresses for the same reason, in my opinion. So understanding what makes Barb's plaque different from Bill's plaque and treating that is what I do in my practice. And again, go back to what do I talk about? I talk about exercise, right? I have people who have a lot of plaque and elevated coronary calcium because they run 100 miles a week. Okay, let's talk about recovery. Let's talk about making sure that you are recovering appropriately and we don't have excess stress hormone that's contributing, right? For some people, it's Lp(a), and we do our best to mitigate that risk with everything else. For some people, it is a genetic predisposition that's not Lp(a). For some people, it's their insulin resistance and metabolic syndrome. That's a pretty straightforward one for all of us here. So it depends, right? It really depends, and this is the point about personalization of medicine, and it's really easy to be a clinician to do this as a one-off. It is really, really hard to be Dave and Adrian and trying to figure this out at the population level and to try to understand these different phenotypes so that we can have science that actually might back up or maybe refute what I'm standing up here and saying. That's really hard, but someday we'll get there. I believe in them.
Have you seen regression of CAC scores over time in your patients?
Sorta. Yes, CAC can come down. It's documented. It's a thing. Most cardiologists never target that. Most people will tell you it's not really a thing. Pathophysiologically, it doesn't make an enormous amount of sense to me that we will reabsorb a bunch of calcium. Most of the time, we think of that as reasonably stable, inert, inactive plaque. Is it possible? Yes, of course it's possible. Do I know exactly what CAC regression means in terms of risk? Is that better than stabilization? Is IMT regression better than stabilization? It makes everybody feel better, right? My former business partner who was here last year loves to see regression in absolutely everybody, and he will put everybody on everything possible to get as much plaque regression as possible. Is that better than stabilization? Makes us feel better, makes the numbers look better. Does it reduce events? Don't know. That's a better question.
If you consider plaque as needing secondary prevention for someone on ketogenic diet, would you consider using statins?
It depends. Sorry. Would I consider it? Yes, I will consider the whole spectrum of tools in my arsenal to prevent this disease. Will I recognize that there are risks and harms associated with every intervention that I offer? Absolutely. Are the risks and harms with pharmacotherapy maybe higher than they would be for other things? Absolutely, right? This is an individualized discussion. Have I used statins and other lipid-lowering therapy for secondary prevention in patients on ketogenic diet? Yes, I have. Absolutely, I have. Have we had a conversation about the risks and benefits of that with respect to number needed to treat, with respect to insulin resistance, with respect to myalgia, myopathy, and other possible side effects? Absolutely. Do I prefer to use statins at a very low dose and switch to combination therapy or other agents if I feel like we need some pleiotropic pharmacologic effects to help prevent progression of plaque? Yeah. Yeah, I do.
Is erectile dysfunction an early indicator of cardiovascular risk and an impending heart attack?
Impending heart attack, not necessarily, but is it a potential marker of atherosclerotic cardiovascular disease? Yes, until proven otherwise. So there are macrovascular, like those are blood vessels with names that I can treat, problems that lead to erectile dysfunction. So those are the arteries in the pelvis. There are also microvascular, so these are the small, tiny arteries that do not have names that I cannot fix, that are in the glands and in the head of the penis that can be affected by things especially like diabetes and kidney disease. So until that workup has been done, erectile dysfunction should be considered a marker of atherosclerotic disease until proven otherwise. There are many other things that can cause it, absolutely. There are other treatments and other things. However, if that is a presenting symptom, we always use that as an opportunity to have a conversation about screening and to look for ASCVD.
So do you think the nattokinase may have had a negative impact or that it just didn't have a positive impact?
My hypothesis is that it just was not a positive impact, right? And we were on the higher doses that were used in that trial. I think it was a high quality source, and I still think it may work for other people. But to achieve those doses, there is no product in this country that has more than 4,000 IFU per capsule. Almost all of them are actually 2,000 IFU per capsule. The dose in the trial was about 12,000, 10 to 12,000 to get an effect. So it's a lot of capsules. I believe that there is going to be eventually a signal for bleeding risk with the kinases. It has not been demonstrated in the trials that have been done yet, but based on mechanism of action, it would be weird to believe that there's no increase in bleeding risk for the nattokinase, lumbar kinase agents. So, you know, we'll see. It doesn't mean I'll never use it again. It just means for this particular individual, it wasn't helpful.
Okay, so why are so many heart attacks and strokes silent? Are they really asymptomatic, or is it the symptoms are relatively mild so people don't realize that it's happening?
Yes. I don't know.
Okay. And what's your plan to lower mom's homocysteine? From Dr. John Cripps, he's not here, but he's an awesome guy.
Methylated B vitamins, you'll be happy to know the last time I checked it, it was 8.